Hello and thank you. My name's Jason Webb. I'm orthopaedic surgeon and head of the Regional Prosthetic Joint Infection Service in Bristol. I want to thank Professor Dave Sokart for asking me to give this talk, initially at an event up in London, but obviously now via Zoom. And I'd also like to thank Vipin Asopa for advising on how to get this talk to you. So if you are listening to this talk, one, his technology advice has worked, and number two, you've got nothing else better to do than to watch a talk about filth and prosthetic joint infection. So here we go. As I say, I work in Bristol and I'm the regional lead for this and the lead also for our trust for MSK infection control. I'm a member of the International Consensus Meeting Group that we last met in 2018. And so a lot of the evidence base for this will be based on the guidelines. And for the point of your exams, you should be able to always reference back to both the international consensus advice. It's all available for you online. And then for more regionally pertinent stuff, you've got the UK PJI consensus group. Again, we've met twice now, last year and then again at the beginning of this year. And some of the guidelines as regards who should be doing this sort of work have come from both of those. So that's quite useful for you to be able to quote. The final two areas that I'll be drawing on, one is obviously my own clinical practice and my background in research in this area. And then also the other research that's come out of Bristol, because there's a large research institute here led by my colleagues Ashley Blom and Mike Whitehouse, which has done a lot of key research in this area. So if you want to discuss how to manage prosthetic joint infection in the exam and then going forward into your everyday career, first of all, you want to prevent it. I do lectures on prevention, and that is the key part, really. If you're going to win the battle, win it by never having to fight it. But if you are presented with a prosthetic joint infection, just using some simple questions will help to guide you in what you should be doing and what is achievable and what you should be communicating. So first of all, what should be done about an infection? The first thing you therefore have to come to decide is, what are your goals of treatment? So we run in our infection clinic a multidisciplinary team, and you'll come to realize how important that is as regards the consensus on how these should be managed. But in each case, we have to enter into a dialogue with the patient and put forward the realistic goals for prosthetic joint infection. You can't hope to, most importantly, be able to prevent, but also to treat prosthetic joint infection unless you understand the basic science and what is involved with biomaterial related infections. Any of these type appearances in your clinic are a cause for your heart to sink, but you've got to have a steady process of how to manage them. So the first thing you need to disguise, setting those goals, is, can we cure this one or can we only control it? And to know that, you've got to know the patient you're dealing with, but you also need to know that the enemy that you're going to be fighting. And in the vast majority of cases, we'll be dealing with bacteria. The problem, however, is that the bacteria we deal with in surgery, and particularly in orthopedics, behave differently to how the sort of 19th century originators of the founders of modern bacteriology, people like Pasteur, Koch, and Kohn. It was really Koch who came up with the idea of Koch's postulates, and also this concept of bacteria swimming around, planktonic bacteria swimming around in solution. And because that has been the prevalent idea going forward in microbiology, what we haven't had sight on until more recently, in the last 5 decades or so, is that actually bacteria preferentially like to lie on surfaces because it gives them some protection. And so they're not planktonic, but they are sessile. And it is the fact that, one, they will lie on a surface, and all of our implants provide them with surfaces to lie on. Both any of the biomaterials and any damaged tissues are perfect for bacteria to settle upon. But then bacteria then produce a matrix, a glycocalyx, that once it forms over them is known as the biofilm. And so these are a biofilm mediated infection. And unless you understand that, you can't help to prevent it, and you can't hope to treat it, because it's a 3D structure with bacteria protected by both chemical, physical, and immunological means within the biofilm. Now, the other thing you need to appreciate is that every single operation we do is contaminated with bacteria. And the key to preventing that contamination to becoming an overt infection is to make sure the inoculum size remains small enough. So you can either be a clean, quick, good surgeon. That's one way of doing it. Number two, you'll have help with things like antibiotics to kill the bacteria as they alight onto the surfaces. And number three, you want to wash away any of the bacteria that have developed during the operation. And so you want to ensure you use some form of lavage during your operations. Okay, so those are some key ideas in wanting to prevent the biofilm. Because although all the research is done in vitro, it's fairly coherent that the biofilm probably takes about 24 to 36 hours, roughly, of that region to form a resolute biofilm. So here, stage one happens in every case, and to a certain degree, stage two as well. So that is the conditioning film of plasma proteins that allow the bacteria to collect. But if at stage two, you've got a large enough inoculum, you are condemned then to go on to stage three, where enough of them are producing a glycocalyx so that you get a biofilm. And you've lost by that stage. That will become stage four, which is a mature biofilm. That patient's wound won't heal. They'll have an infection that presents in the first 3 to 4 weeks, or maybe a bit later until it presents if someone gives antibiotics to cause it to present later. But you're only going to then manage that by removing the biofilm and the implants with them. So everything you can do is to keep your inoculum down. For the rest of this talk, we're not going to talk about prevention. We're going to talk about management. And so your options are set out by the original paper from the New England Journal of Medicine with Zimmerli, Trampers, and Oxner, really gives you the ways to structure your thought processes. So depending on how it presents and the quality of the patient as regards comorbidities, you decide which options you undertake. And this is a very helpful table from that paper that you can use for going forward. So let's just focus to begin with on an often used, but everyone wants to sort of deny, the options of control. We're not going to cure this patient. We just want to control the infection. Now, there are control or salvage surgical procedures, because as you'll see, to cure, and in a moment, you'll see you want to give the patient function. But if you can't really achieve that, then there are other things you can do. So you can remove the joint. So very elderly patient, hemiarthroplasty, gets infected, they're very unfit, you want one operation to sort it, you'd probably do an excision arthroplasty. So it's a salvage procedure, it's not a cure, because they're unlikely to walk well, if at all, after that. In the knee joint, you might undertake an arthrodesis. After you've given up the ghost, you've tried to treat them for the last couple of years, nothing else to do, let's arthrodese it. Or indeed, you might amputate it. But one other procedure that goes into this group is the washout. A washout of a joint has no place in definitive management of prosthetic joint infection. And if it's seen on an operation note, that is not satisfactory. The only real indication to use a washout is when a patient comes in and they are in septic shock and they're going to die. And it's middle of the night and you have to just let that pus out. And that is fine. Then a washout is satisfactory. But it's only under the understanding that you're then going to proceed within the next few days or within the next week or so to either a first or second stage or a DAIR. The other one that we use widely in our infection clinic, our prosthetic joint infection clinic, because we've got other members of the multidisciplinary team, including the microbiologist there, is in discussion with the patients who've probably been through treatment, it hasn't worked, they've been through maybe a 2-stage, and they go, look, I don't want to do any more of this. I just want to have it suppressed. You have to discuss all the pros and cons of the potential side effects of the antibiotics and the developing resistance among the bacteria, such that you might need to change antibiotics over time, and the possible relapses. But many of our really elderly patients will say, look, I just want to undergo antibiotic suppression. Right, let's move on to be slightly more optimistic and talk about cure. So I would define, and the consensus defines, cure of prosthetic joint infection as both eradicating the infection and restoring the function of that joint for the patient. And the two key elements to that, and the most important one to begin with, is surgical debridement, but you need to combine that with focused antibiotic therapy. And to achieve those, you need a cunning plan. What is the evidence? The reason I put this in here is, for the exam, there's a very easy means of answering a prosthetic joint infection question nowadays. But the phrase that must disappear is gold standard. There is no such thing as a gold standard in banking terms anymore. Nothing has been measured against gold for over 100 years. And there is no such thing, although it's very popular in the North American press of talking about there is a gold standard, because that which is put forward as a gold standard is often the 2-stage revision for prosthetic joint infection. And it's very out of date to have that sort of sentiment. The INFORM trial, which was the multi-center randomized controlled trial led by Bristol, looking at 1 versus 2-stage revision for prosthetic joint infection, we'll have results from that. The final results are going to be available within the next 4 weeks. But there are many different work streams in that research project, a lot of it was looking at the systematic review work, because Bristol's got a very well-established systematic review team. And the important, one of the important papers that came out of that was looking at the largest and most up-to-date systematic review on 1 versus 2-stage, and then opening that up into all of the original research units from around the world and saying, can you collate in even more data from the research you've done since your published papers? But the key bit to note here is that what has the best results as regarding prosthetic joint infection? Is it a 1-stage or a 2-stage? Well, it's neither. If you look at them, there is no significant difference. They will have approximately a 90% chance of treating the infection. As regards getting to cure, that's a difficult one, because if you look at the patients long enough in the future, you'll realize that many may relapse in a late fashion, but most papers look at either 1 or 2 year disease, infection-free survival following the surgery. So either a 1-stage or a 2-stage, you can quote that the literature suggests probably about a 90% success rate. These were the centres in the UK and then in Sweden more latterly that took part in the INFORM trial. And as I say, within the next month, we should have the final outcome of the work. Anyway, moving on. Next question. Where should one be managing infection? Now, both the international and the UK consensus are very clear on this. It needs to be a larger centre and one that can run a proper MDT on a regular basis. So your simple answer is that. And then that helps with taking the pressure off the smaller units who don't like having to deal with them, because now they know they have to refer them on. But the key part that will be required everywhere, because the larger centres cannot cope with the workload, and that workload is going up, not necessarily because infection rates are going up, but because as the volume of joint replacements that are done, then it goes with that there will just be a higher number of infections that need to be dealt with. So you need to be able to do a DAIR, a debridement, antibiotics and implant retention in every unit. But these are your treatment options. We've already mentioned those that are curative and those that are purely salvage or control type procedures. So what else do you need to know if you are going to undertake a debridement and implant retention? Because it's a very varied tool and you need to be doing it well if you hope to get good results. First things, the advice both locally and internationally is that it should be performed and led by an experienced arthroplasty surgeon, preferably one who has a particular interest in prosthetic joint infection. When it is not a rushed middle of the night procedure, you have got time to plan this, and in fact, the results are going to be much better if you do. So the surgical procedures that I'm going to focus on and give you a sort of how to do it in the remainder of this talk are the DAIR, the debridement, antibiotics and implant retention, and the 2-stage. And then I will very briefly mention the 1-stage because essentially it's a 2-stage, just done quite quickly. So what are the criteria as regards the debridement and implant retention? Okay. Well, this is where you need to talk about how you're going to do it. What are the key features that make us successful? First things first. The reason you don't want to rush is your chances of success are going to be significantly increased if you have some information about the index operation. So the patient gets reported on the trauma meeting the next day and they say, well, this patient had this, they can't remember where they had it, it was probably about 5 years ago. It's worth trying to get to the bottom of it. Try to find out which surgeon, which hospital, and get the details, because you want the implant details, because you want to know that when you change the modular components, you've got the right size and the right implants. Okay. Withhold antibiotics if the patient's clinically well enough. Okay. If not, make sure that you've got a fluid sample from the joint and good blood cultures, etc., before you start antibiotics. Okay. If they're ill, liaise early with the microbiologist so that they can tell you what samples they want and what forms they want them to be sent. Make sure you cross-match appropriate amount of blood. You can't use cell salvage in these cases because they're infected and they will bleed a lot if you're doing the operation properly. And warn the anaesthetist, because the anaesthetist may still be in the mode of expecting a washout, which is open the wound up, wash it out, and close it up again. Those are unacceptable as regards this surgical procedure, and you need to warn the anaesthetist. This is a big operation. There's going to be a big debridement. There's going to be a lot of bleeding. Next thing, how do you get in there? There'll be usually a mature scar. Now, there may be a sinus coming out of it, but there may be a mature scar and you need to excise it. The way I was always taught to do it, and the way that works well, is by holding 2 22 blades in your hand like that, because you have a very neat scar excision, okay? Do that in every case. You'll see in a moment some pictures from a paper I did based on my time at the Endo Clinic, and you'll see that when you don't do it that way, how untidy the excision scar can be. This is not minimal access surgery. You need to use an extensile approach. You need to explore the old approach and use the one that you're more familiar with. Maybe the most common approach for dedicated hip surgeons is the posterior approach. You would want to do that. If they'd used an old lateral approach, I would explore that one because the infection will through that route, but I would still go via a posterior approach because you're going to get a much better access. You need to expose all the implants and dislocate them. And this then ensures that you've got a proper exposure. And I think that is the key element. It's not necessarily, although exchanging the modular components is important, if you've got enough exposure to dislocate and be able to exchange them, then you've done a good enough approach. Sampling, vital in every infection procedure. You need to have a dedicated sampling tray as described by Oxford. You need to have both microbiology and histology samples taken. Of microbiology, you need at least 5. They need to be got to the lab promptly. You should also have some blood culture bottles available, so that because if you inject some fluid into those, then your any anaerobes that are around in these polymicrobial type infections will not die whilst they're waiting to get to the laboratory. And tissue samples are better for the lab. So the fluid samples, you can send one as well, but those that go into the blood culture bottles fare better. And you have to have a lab. You know, you're going to have this if you're in a center where you've got an MDT, but they know to do prolonged cultures and late reculturing for those hard to grow bacteria, because all of those will give us the precise antibiotics to manage the infection further. In the first instance, the reason you need to have liaised with your microbiologist is they know what the current trends in the resistant profile of your local bacteria, and they will tell you the empiric antibiotics to start once you've taken your samples. Next thing, check the implants are stable, because if they're not, then this can become a one-stage revision, because you don't want to leave any instability in implants, because there is fairly robust basic science research that shows loose implants become more likely to become infected because movement, micro movement at interfaces promotes the development of infections, and particularly promotes in the development of a biofilm, a membrane and a biofilm, which then bacteria can exploit. If you've got cemented implants, burr the surface, because they will have been put in with antibiotic-loaded cement. And Bob Spencer, one of my trainers, did a study looking at the local concentrations of gentamicin that's released if you burr the cement at revision. And it's significant, very high local levels that are going to be helpful in your treatment. Then there's the debridement. So you've got in, you've got down, you've got the implants exposed, you've changed the modular bits. And then the key bit, you stop and you think, right, now I start the debridement. And I always start deep, and I work systematically around the wound, and then I come up to the next layer, around, and then up to the next layer and around. Okay, it takes time. You need to cut out a lot of tissue, at least a kidney dish. You haven't done enough. When you get into an infected case, you get that punctate bleeding everywhere. It's so annoying, because if you diatherm it, it keeps going. It just sprouts up next to it. Once you have debrided back to healthy bleeding tissue, you can then use diathermy, because there are discrete bleeding points. So that is your guide. If you are still in diffusely bleeding tissue with that slightly glossy white appearance, you haven't debrided enough. Once you get back to the healthy tissue, you can then control bleeding, and then you can use lavage, and use a lot of lavage, 6 litres, I think the consensus meeting suggests at least. So that's the key. You have to debride enough. It is a surgical treatment with antibiotics helping. So this is a photo from my time at the Ender Clinic. Obviously, this is an actual one-stage revision that they sort of have championed over the years, but you cut out a lot of tissue, okay? Next, you've done all of that and you've done your big lavage. Now you want to have some fresh instruments, and you want to put in your new liner and your new head, if applicable. And then you want to close. So you want to get hemostasis at this time. We don't use drains in our unit, haven't used for many years. Drains really don't offer much. And if you're going to use some local antibiotic carriers, something with a calcium sulfate or calcium phosphate loaded carriers, then you don't want drains, because they'll be draining away the antibiotic elution. And then you need meticulous closure. They always say the 2 things you should not debride are nerves and arteries, obviously. I have one other. I have the actual fascia, the fascia lata, because if you debride that too widely, you will not be able to close over the deep layers, and you will not succeed in getting a satisfactory closure. So obviously you have to take out a sinus that's coming through, but then you want to try and achieve a good fascial closure in order to give yourself a better chance of obtaining clearance and obtaining a well-healed wound. So meticulous closure. What about the results of DAIR? This is the really key bit. If you look at a systematic review I did some years ago, you can see there's a very varied results within the literature. And it does unfortunately show that the USA typically was not getting as good a results, but that's because in their studies, in their cohorts, they were not exchanging the modular components. And that probably acts as a surrogate marker that they weren't getting as good a debridement, etc. done. And then for units that were always exchanging it, they were getting better figures. But again, from the Bristol Systematic Reviews group, as part of the National Joint, as part of the INFORM trial, there's a more up-to-date study. It's the largest one of its nature, and that has looked at 99 DAIR studies and showed that the infection control ranged in those studies ranged from 11 to 100%, but the pooled estimate control rate is about 61%. So if you're asked in the exam, or if you're asked by a patient, what is the chance of controlling this acutely presenting infection, someone who's only had symptoms for maybe 3 weeks, so it's the wound that doesn't heal after the operation, or it's the late hip that's been doing fine for 15 years, the patient then gets a pneumonia or a urinary tract infection, and a week later they get a sore joint. If those people come in, what is the chance of successfully treating their infection? Well, it's about 60%. So sort of quote to the patients, about 2/3 at best, okay? So there we are. In summary, what would you do about a DAIR? It's for patients with short duration of symptoms. It's a radical surgery. You exchange the parts that you can. You avoid antibiotics before it if you can. You give 2 weeks of IV antibiotics afterwards, and then we've always switched to oral antibiotics early. I'll talk about that in the next bit on the 2-stage. But you must have stable implants and good soft tissues and a good host. Susceptible organisms help as regards when you review the results, and you're looking at a 2/3 success rate. Right, 2-stage. Obviously, the surgical debridement bits are the same, but let's just look at the ideas here. These tend to be more prolonged chronic infections, okay? So you will get a referral from one of your hub centers, and they'll come in usually, not as an acute referral, but they'll come into your infection clinic. You can do the MDT and you'll make your plans for management. So in that one, you'll have your microbiologist, you'll have the patient, you'll have the surgeons, you'll have the physios, you'll have other help, the radiologist, to ensure that you make the right decision. And we run our MDT there. We have a weekly separate MDT for our revision work, and where we can discuss infections as well. But the MDT at our infection clinic is vital because you've got, well, basically you've got the microbiologist, without whom you cannot run this service. It's a microbiology service with surgical surgeons as technicians to help with the work. So this is our one. We have a separate hip and a knee infection clinics on different weeks, but we have all of these elements to our service. The next thing is you need to investigate the patient. Sometimes we'll be sent a patient and it's not infected, but we will investigate to exclude infection. But we also want to investigate to get the details of the infection. First of all, blood tests. The simple blood tests are still the best. CRP is more helpful than, although you would do a full blood count, CRP is more reliable than an ESR, which has much more prolonged responses and changes in its level. D-dimer is a hot potato, popular from the Parvizi's group research. There is not much information on it yet, but it's being developed as a commercial simple test. So controversial, it's much more simple at present to stick with a CRP. Imaging. Is imaging helpful? Well, it is when you have the original X-ray and then 6 months down the line, you can see a rapid destruction and bone loss. This really could only be infection. The pathognomic sign is periostitis that you typically see medially on the femur, but you'll often not see it. But gross, rapidly progressive bone loss, you've got to think of infection. Next bit of investigation that involves radiology is to get an aspiration from the joint, either ultrasound or images intensifier guided. That's vital because that will give us fluid that will allow us to culture the organism and get its sensitivities, and will help us in our surgical plan. As regards using other imaging modalities such as MRI, CT or bone scan, these are not part of the diagnostic process, but they can be part of that surgical planning for looking at soft tissue collections, etc. Now, once you've got that, you can decide it's unlikely going to be a DAIR because those tend to come in as a more urgent referral. But you can decide whether you want to do a 1-stage or a 2-stage, depending on what you prefer. You know, we know that from the literature, there's no significant difference in the outcome. But it would be based on you know, other matters such as the surgical reconstruction and the comorbidities of the patient. The next thing is you need your microbiological plan. So you've taken your fluid off and you can grow your sensitivities. You can see it's something like a coagulase negative staphylococcus, and you can see what you're going to use if you're going to use antibiotic loaded cement or local carriers, and also in your antibiotics to be given systemically at the time of the operation and afterwards. So that helps. One proviso, you must remember that these are quite often polymicrobial infections. You often will only get one organism growing from an aspiration. And indeed also that the studies suggest that maybe only about 50 to 60% correlation between the aspirated cultured organisms and those that you grow then when you do the surgery and do your definitive sampling. So remember, the definitive intraoperative sampling is the most important, but having an idea preoperatively is very helpful. You then want to schedule it. You want to schedule your theatre time. You know that it's going to be a long case. You've got to have enough space to do it. You'll have to move cases around. And you want to do 2 consultant operating. Having been doing these for years, I cannot tell you how much nicer it is with the more modern vogue, both from the BOA, from the UK PJI consensus group, and from the international consensus group, of the benefits of having 2 experienced consultants doing these cases. Okay, it takes a lot of the stress off and it makes the surgery faster and I'm sure much better for the patient. You plan your surgical tactic. As you do with any operation, particularly any revision operation, you've got to have a plan going in. You must plan your antibiotic prophylaxis based on your culture results, and then based on your local organisms, if it's a culture negative infection. At the endoclinic, they would keep sampling week after week until they grew something, because they always wanted to manage these as a 1-stage, and they always wanted to therefore have the organisms beforehand, even though there's only that maybe up to 60% correlation, but they would want that. Whereas in most centers, we would be happy with proceeding with the case, even if it was culture negative at that stage, because it often won't be culture negative once you've taken all your samples. Again, excision, cut out the wound. This is what it looks like if you don't do my 2-knife technique. This is where someone's used the blade down one side and then the other side. It's an excision of the wound, which is good, but it can be so much neater if you use that 2-knife technique. Right, so here you are going down through the surface, and we'll have a look at some more photos in a bit. Sampling, again, as before, as I've stated before, you've got your sampling tray. What about the synovial fluid you get straight away? Well, that's very easy and a very cheap way to do that. Don't use one of the expensive, things like the alpha defensin, commercially available ones. Just use your urine dipstick. Very sensitive, very specific, better than the more expensive commercial ones. And the only worry about, well, if it's blood stained, well, if you do it before you go through the fascia, if you stick a needle through and take it, then it's much less likely to be blood stained. But even if it is blood stained, just sit it on the edge, just put it into a sample pot, let it sit on the edge, on the shelf in theatre while you get on to do a bit more work. The blood will settle. The clearer fluid at the top will be helpful after, 5 minutes, 10 minutes, and then one of your staff can take that fluid and test it. So leukocyte esterase is very helpful. Sampling, as I say, never use a swabs. Pus swabs like that you see in the top right picture have no place in modern prosthetic joint infection treatment. You need tissue samples, and the Oxford group tell us you need some fluid, you need some of the synovium, some of the scar tissue, and then the interface on the femur and on the acetabulum. And that's your basic. You can do more than that, but you shouldn't do less. Then you need your radical debridement that we've discussed already. for your DAIR. It's the same debridement, but in this case, you're going to be removing more because you're taking all of the implants out. Okay, anything that doesn't look like healthy tissue needs to come out. That can be the whole part of the proximal femur with some of the bone if it looks like it's full of osteomyelitis. Getting back to tissue that you can see that looks normal, bleeds in a normal fashion, that you can control with normal diathermy. Okay, lots of techniques of getting out well-fixed implants. Sometimes the infection helps you by having loosened the implants, but you may be requiring things such as extended trochanteric osteotomies if you've got long uncemented implants that are that are still distally fixed. So again, same image as before. You need a radical debridement, removing tissue. Your biofilm sits in that tissue. You've cut it out, you're going to have a better chance of success. If you've left a load of tissue, if you're not good at doing your debridements, your results are going to be far less good. Again, lavage, lavage, lavage. It doesn't matter what it is. Saline's fine. We use chlorhexidine, dilute chlorhexidine, followed by saline, because of studies that were done in our unit. America is now popularizing the use of dilute betadine. That's fine as well, but it's expensive. There are also some commercially available antibiotic and antiseptic eluting solutions. Again, very expensive, no benefit over just washing and washing. Then you reassess the wound. Make sure that you haven't missed any little pockets or collections. Then think about your local antibiotics. Now, spacers are great. We've done some qualitative work in the INFORM trial, which shows that patients don't really like spacers, but actually they don't like anything to do with infection. So they don't like two stages. They don't really like one stage. They wish they weren't there in the first place. But spacers have the benefits of releasing loads of antibiotics, or if you are doing a two-stage, and also keeping the tissues out to length so that they don't constrict so much in between the stages. But there are a variety of ways you can do spacers, and you can also put your cement beads in as well. I'll talk about those. The Prosthetic was one from North America, where you have a mold that you make the implants, and then in the UK, the Kiwi or the Kumar's type approach from Exeter, which is where you're just putting in, if you like, a badly cemented hip, stem and socket. They are all options, but they are just a means of keeping the tissues to length and releasing high doses of local antibiotics. As regards making beads, surface area as regards antibiotic elution from bone cement is key. So I always make my beads like biconcave discs, like blood cells, which of course have evolved to have the highest possible surface area. And then once they've set, I do drill holes through them and then put them on a string of orthocord and leave those in the wound if I'm doing a two-stage. Other means of local release include calcium sulfate and calcium phosphate carriers that you can add antibiotics to, and meshes and gels and other things. So they're all options. Remember, you've got to think about the effects of some of these carriers as they liquefy. Some of them can, calcium can be absorbed, but also they do produce a lot of fluid, and that can cause problems with coming out of the wound if it's not closed properly, and therefore close the wound really well. We will often use large stay sutures over, meticulous closure of the layers, and then large stay sutures with having tied that over gauze that is held over just sort of normal nylon sutures. I like using barb type sutures for closure. The better seal you can get, the better results you get as regards preventing transudation of bacteria back into the wound. We don't use a drain. We then give antibiotics based empirically to begin with, whilst you wait for the culture results. And then in this interval between the stages, you monitor the patient with their CRPs every, maybe twice a week. In our unit, we traditionally have always done an early oral switch, and we use a CRP of less than 50 as a rough guide, and then they would be switched from their IVs to their oral antibiotics. Our microbiologists have done this for many years, published it, it's good results. It goes against maybe the grain of people who would use these long outpatient IV antibiotic therapies. But fortunately, the Oxford Multi-Centre group have then corroborated our type of approach and have shown that yes, an early oral switch is fine and has no detriment to the outcome of managing orthopedic infections. Now you're at this interval, you need to be planning the second stage. Zimmerli and Borens and people like that and Trampers have come up with these concepts of obviously there's the 1 stage, but then there's the 2 stage, whether you want to do a rapid 2 stage or a more prolonged 2 stage. Nothing should be too prolonged. Patients don't cope well. There's a high morbidity and even mortality rate between the stages. So getting back in at appropriate time, maybe 6-8 weeks later is fine, but you can go in earlier, a rapid 2 stage. If you don't look like you've got an osteomyelitis type scenario, you've done your debridement, you get all your cultures back, we will go back in at an earlier stage to minimize the suffering of the patient. The benefit of a 2 stage is you get 2 major debridements. So you go back in again and you can do another significant debridement. If we've got time, we'll do another MDT in our infection team, but if not, we will communicate the same with one of our weekly MDTs to allow us plan the reconstruction based on our findings and further imaging we do once the implants are out so that you can plan things even further. Even if you need to then plan for bespoke custom-made implants, you can do that imaging after they've had the first stage and have them made. There's this idea of stopping antibiotics about 2 weeks before your planned second stage. We've just never done that in our unit. And in fact, it's fallen out of fashion fairly universally. So no antibiotic holiday, keep those antibiotics going up until the second stage because, antibiotics are not the cure, but there's no point stopping them when you're still doing your active treatment. You might as well optimize it there and then get on with your second surgery because, again, surgery is the cure. Long-term antibiotic suppression isn't. Then you do your second stage revision. At that, yes, further sampling. We send off frozen section, and we also do the leukocyte esterase strip again. It would be rare to have to change your mind. Your own opinion of the surgical bed is often fairly reliable. You know when you go in there and you go, all right, we haven't won here. We need to do another debridement. And you will have made a battle plan, a surgical plan with plans A, B, C, D, even E, on how you're going to reconstruct this on the day. Traditionally, based on the time I had at the endo clinic, you would reconstruct with cemented implants. But there's good evidence in the literature of units that use uncemented just as successfully. So I don't think it matters whether you reconstruct with cemented, uncemented, or hybrid. And in fact, we use all of those options at our unit. It really depends on what you think will reconstruct the joint the best. However, after such debridements, you often find stability is a problem. So using something either a tripolar bearing or a constrained mechanism is something to be bearing in mind, often with the requirement because of all of the soft tissue loss, muscle loss. And then we keep on antibiotics until the cultures from that second operation, because we'll have sent more samples. If they all come back negative or inconclusive, then we will stop at that stage. But we do keep them going for that time, just post-operatively. But some units just give the prophylactic antibiotics at that stage. And I think that probably scientifically, that's probably more robust. And then finally, we follow them up because these patients are not cured. I regard these patients as with a sort of lifelong condition. We will have hopefully put them into a really good remission that they may well not have a relapse within, and that would be great. But we want to keep them a view on them in the long term. What about a 1 stage? Just very briefly at the end. Well, what a 1 stage arthroplasty? It's just a 2 stage under 1 anesthetic. And the key bits that we do, I like doing 1 stage revisions, is that you've got to have all your definitive plans ready and available there, having developed those in your MDT. You definitely need 2 surgeons, and you need 2 theatre scrub teams, because you basically want have both surgeons starting. Then one will go off as you're getting towards the end of the first stage bit of it, where you've taken everything out and you're doing your debridement and the wash. First stage, you go off, have a cup of tea, have a quick sandwich, change all your outfits and come in. The surgeon who remained in theatre will have closed up the wound, and then he and the first theatre team will have gone out, and all of those instruments, those contaminated instruments, will be gone. Then what we do in our unit is we put 2 sets of surgical drapes on with the first setup. We then remove the top one, keeping the bottom one there. And then when the second team comes in, they put a new set of drapes on top of that one. So again, there are 2, and a whole new set of instruments, the instruments that are going to be used to reconstruct the joint. If you've been operating for a while, know the half-life of your antibiotics, but also if there's been a lot of bleeding, the antibiotics will have leached out of the wound, so a second dose is often advisable. And you know that you can bail to a 2-stage if you find anything during the operation that makes you uncomfortable to go on. So that's the only difference with the 1-stage. And remember, the results are on systematic review are the same. So there you are, just touching on some of the subjects that I think you would want to be able to talk about if you were asked about how you manage prosthetic joint infection in the exam. Thank you for your attention.